Caine, for whom this lecture series is named. You could, I suppose, contend that I stalked Dr. Caine. He and I were medical students together in Baltimore. We were on the house staff together in Nashville, and we shared a practice in internal medicine for, goodness, can it be this long? For 35 years. So I can comment firsthand. I can tell you that he was a consummate clinician. He was devoted to teaching. In 2001, the American College of Physicians recognized him as the National Volunteer Teacher of the Year. He had a powerful personality which was directed toward his patients' betterment. He was the first oncologist in the Chattanooga-Hamilton County area, and it was a privilege to have him as a friend and as a colleague. The Caine lectureship today will be presented by Ronald H. Lands, MD. I could tell you that he was a summa cum laude graduate of Tennessee Tech University in chemistry. His MD, his residency in internal medicine, his fellowship in hematology oncology were at the University of Tennessee College of Medicine in Memphis. Like me, he's an Army veteran of 4 years. Weren't they good years? Splitting his time between Fort Campbell and the William Beaumont Army Medical Center in Texas. He's currently a clinical professor of medicine at the UT Graduate School of Medicine in Knoxville. He is in clinical practice in hematology in Knoxville. He has multiple awards as a teacher. He also, along the way, earned an MFA, a Master of Fine Arts from Queen's University in Charlotte, and this also informs an aspect of his career. That as a writer of short stories, poetry, essays. And what he's telling us about in this endeavor is that rich vein within each patient that changes them from being the 49-year-old with diabetes to a 49-year-old human being who is a father, a colleague, a friend, a citizen, helping us establish those vital links between patients and the warm, rich human beings who reside in those bodies. So I'm ready to hear what he's got to tell us, and please join me in welcoming Ronald Lands.
Well, thank you for that perfect introduction. And I appreciate, I'm flattered to be able to be a part of this lectureship that honors the memory of Dr. Caine. I've learned a little about him over the last few months. I never met him, but I recognize what I've seen, the pattern of the kind of doctor that I've always admired and often tried to emulate over my career. The path of least resistance, when you're offered an opportunity to talk and no one puts any restrictions on what you say, is to use the opportunity to ventilate about what's wrong with medicine and to lament the way things are now compared to the way we imagined they were years ago. Life is full of reality: RVUs, administration, billing, politics, burnout, loss of satisfaction in patient care. And you can buy a book on Amazon and read all that you want, because I'm taking a different view today. I'm not going to mention those things except for what they've done to the way we practice. Now more than ever, when the opportunity to practice medicine is a breathtaking experience, and one we should savor with each wave of information that just washes over us, we've let our patients become strangers because these other things has crowded them out. So my comments today are a bit unusual for an internal medicine grand rounds, even for the grand rounds I've given in the past. There will be no double-blind, randomized clinical trials, hazard ratios, or formulas to memorize. I've written an essay about what I believe to be the essence of medicine, the intangible, unmeasurable things that keep physicians working past retirement, despite their own physical infirmities, long past the point where they need the money, power, or prestige. It's about the unique, almost sacred relationship that evolves when a story is shared between patients and their doctors. So sit back and relax. I'm going to tell you a story. Actually, it's several stories, and it follows three strands. First, I'll refresh your memory on the narrative structure of a story. I have some clinical stories about a particular patient in my clinic and a few others along the way, and then my personal story as to how I'm here today. I've entitled it, Not as a Stranger. Every story ever told since cavemen gathered around an open fire and bragged about their conquest has a beginning. The beginning is a necessity. It describes the way things were before they are the way they are now. Whether it's a grandiose statement such as, "In the beginning, God created the heavens and the earth," or a bedtime story your mother started with, "Once upon a time," something establishes how things were before things changed. If you ask patients to describe what's wrong with them, they'll invariably start here. It's late afternoon in May. I'm in my hematology clinic, my retirement job that some days emphasizes what an oxymoron those words are. I'm with the last patient of the day, last appointment of the week, last barrier between me and a 4-day weekend, which I hope to spend most of on the lake. I'm seeing an elderly black man referred from a charity clinic. I've just spent 30 minutes explaining the nature of his blood problem, what we need to do to figure it out, and the potential consequences of leaving it untended. I ask if he has questions. "No," he said, "I reckon not." He's dressed in an eclectic ensemble, a straw fedora-shaped hat, a loose-fitting, wrinkled tropic-style shirt, and brown, thick wool pants with cuffs. His shoes are light brown with a long, narrow, pointed structure in a European style, not scuffed or worn, so I conclude they're a recent acquisition from Goodwill. He sits with his left leg across his right, his hands folded on his thigh. His face has the caught in a flashbulb look of a husband from 100 years ago who reluctantly agreed to pacify his wife and have his picture made just because a man with a camera was coming through town. He said, "I reckon not," with an air of quiet resignation, like he had been lectured at or lectured to for 70-plus years and had long since given up truly understanding or being given credit for understanding anything. In my mind, I'm in the back bedroom of my grandmother's farmhouse, sitting in the floor, sifting through an old cedar footlocker, looking through a shoebox full of pictures of her parents, siblings, people who had lived and died living the photographs in this box as their only recorded image. I'm holding a photo of my great-grandfather, a man who survived the Civil War only to be captured in this picture, wearing the same bewildered look as my patient. I study his jawline and a smile that looks more like a grimace. I recognize it in my uncles. My great-grandfather, like my patient, dresses with whatever's handy, a suit, coat, and tie with baggy dark work pants and brogans of indeterminate condition, and like my patient, he wears a hat. The smell of cedar and mothballs permeates the air. A volatile mix of feelings washes over me, mystery, emptiness, and insignificance, and somehow I know the man in this image is partly me, that there is no one on earth who carries a living memory of him, and this picture is as much as I'll ever really know. He's a stranger to me and always will be. So once upon a time, I was a young boy in a small town and didn't know I would be or ever want to be a doctor. Those were simple times. Television was the latest great thing. The pictures were still in black and white. Medicine had yet to become the drama depicted on the screen today, where young, attractive actors play physicians and nurses who take care of other young, attractive actors who play the role of the chronically and terminally ill. There were no computers, iPads, or mobile phones, no World Wide Web of internet or social media. But there was the Encyclopedia Britannica, and my dad bought the entire 29-volume gold embossed set with the lifetime subscription to the annual Year in Review. My favorite pastime was to lie on my belly with those enormous books spread out on the floor and turn the pages one at a time, study the pictures, read the captions, unconsciously becoming aware that there was a world beyond the city limits of my small town. Once I happened on a picture of the campus of the United States Military Academy. The cadets were standing in formation on the parade ground, wearing their dress uniforms with full regalia. The caption mentioned the long gray line, a term used to describe the continuum of graduates from the Academy's inception to the present and into the future. The discussion was about the number of presidents, famous generals, and world leaders who were members of that august body. I decided at age 6 that I would go to West Point and someday lead good men into great battles. During middle school, I read Not as a Stranger by Morton Thompson, a novel set in the early 1900s and published in 1954. It follows the main character, Lucas March, on his unlikely journey from childhood through college, medical school, internship, and settling to become a general practitioner in a small town. There was a sense of destiny in this story that was almost as evocative as the sense of history in the West Point picture, a premise that some people are born to be something, regardless of their origins, and are helpless to ignore it. Here are a few words from Thompson's book. But the body is not all, and in some there would be profound differences in the spirit. There would be emphasized pathways in the brain. There would be mutations of the mind, and scientists would begin from ditch diggers, and mathematicians would begin from the sperm of savages. A violinist would be born to the deaf, a hunter to the sightless. And for some of these urges would be dim, troubling impulses, and for some they would be strong, and for some the impulse would be irresistible and become their life, their very life. Watson and Crick had only just started the unraveling of DNA secrets a few years before I was born. The infinite depth, breadth, and durability of the human genome, with its similarities that link us to all forms of life, and its subtle differences that account for the tangible, visible variances that divide us, were still unknown. All I had was the Mendelian genetics that I'd read about in the encyclopedia, and a genealogy that included 5 generations of Appalachian farmers, soldiers, and preachers, none of whom were rich, famous, or inspiring leaders. This novel kept my options open. There were 2 doctors from my town who are fixed in my memory like Norman Rockwell images. Both sat in classrooms in the same elementary and high schools I attended. Their pictures were in the yearbook as freshmen, sophomores, juniors, and seniors, their faces a time-lapse of changes that occurred during adolescence. They were in the chess club, the science club, they played baseball, football, basketball, and after World War II they went to college, then medical school, and after 1 year of a rotating internship they came home. It was not as difficult as Thomas Wolfe and Robert Frost would have us think. They picked up their story where they left off. They joined the Rotary Club, the American Legion, the Methodist, and Churches of Christ. They roamed the sidelines on cool fall Friday nights for the high school football team, sat in hot, sweaty gymnasiums at basketball games, and eventually watched players they had delivered as babies, whose parents were their previous classmates. Their offices opened and closed when the first person showed and the last person was seen. They delivered babies day and night. They made house calls. They knew their patients by their first names. They were general practitioners at a time when GP was a word and not an acronym, spoken always with respect, sometimes with reverence. They were characters straight out of Morton Thompson's novel. The oldest was slowing down by the time I was born. I mowed the yard and weeded flower beds for his wife when I was in grade school. When they weren't home, I'd cup my face with my hands and press my nose against the glass and look through the window into his study. There was a desk against one wall, bookshelves covered another. Journals stacked in the floor surrounded a big leather chair. One summer night, when I was 10 years old, the other doctor took me to surgery without the benefit of a CT scan or a GI consult, found my abscessed appendix, and removed it through an open procedure. I recuperated in the hospital for about a week. A nurse's aide recorded my vital signs every 8 hours on a flow sheet attached to a clipboard that dangled on a string from the foot of my bed. I had a CBC every morning performed on blood taken from a lancet brutally stabbed into the end of my finger. Every day the nurse ripped the adhesive bandage off my surgical site and changed the gauze dressings. Before she dressed it again, she would clean my fingertips and let me feel the thick silk sutures. I was discharged with restrictions, including the prohibition of my returning to my Little League baseball team for the remainder of the summer as a precaution against the errant line drive that was certain to seek me out in right field, hone in on McBurney's point, and rupture my scar. I was enchanted with the rules, the rituals, the smells, the old nurses with swollen ankles, and white stockings with the seam that meandered up the back of their leg. I was enthralled with the young nurse who tried to act old and mature. I was awestruck by the doctor who made rounds at random times with a pack of unfiltered Lucky Strikes in his short-sleeved clinic coat packet, and the aroma of stale tobacco smoke that heralded his entrance into my room. I savored the flat, cold taste of scrambled eggs and toast cooked in the basement cafeteria, and I felt like a member of an exclusive club when the hospital operator announced over the PA system at 9 p.m. that visiting hours are over, and everyone had to leave the building except us, the unhealthy and the healers. There are a finite number of story patterns that the infinite number of known stories seems to fit. Most start with a phase when everything is going well, followed by a time of frustration because of mysterious changes in the quiet contentment of the beginning, then a nightmare stage where nothing seems to go right, and finally some variation of destruction and or death at the end. Scholars argue that the themes for this story arc are also finite, ranging from 1 to 69 if you happen to be a follower of Rudyard Kipling. The most common include these 7: tragedy, comedy, rebirth, rags to riches, voyage and return, killing the monster, and the quest. These are recognizable everywhere, from classics like Romeo and Juliet to any of the many Netflix series now playing, where an alcoholic, womanizing, otherwise disgraced detective moves from the city to escape his reputation and finds a body buried in his newly purchased backyard, which provides him the opportunity to solve a cold case that has defied the local experts for decades and allows him to emerge on the other end of the story, a changed, rejuvenated crime fighter. In each of these, after experiencing the once upon a time, the main character is thrust reluctantly but irreversibly into the middle of the story, presented with conflict after conflict, tensions that escalate unmercifully, relationships, confrontations, and choices that intensify rather than reduce the gravity of the situation. Subplots weave their way in and out of the main story and require more choices, often with life or death consequences required because of the outcomes of previous decisions. The protagonist stands alone, a stranger among strangers, uncertain of who he is for or against him. The middle story is when people visit their internist. Their story is broken. It's a week later, and I see the old man's name at the end of my clinic list. Sometimes the scheduler sends something that I don't, and realize that some people need a more open-ended visit or just aren't likely to show, so they schedule accordingly. His appointment time comes and goes. I look through the computer and find that he didn't keep his date for his bone marrow and his abdominal ultrasound. I review the results of the blood work I did the only day I saw him from the first clinic visit and find that one of his molecular probes for the myeloproliferative syndrome with the worst possible prognosis has returned, and it's abnormal. It took me almost 15 years to complete my voyage and return from home, college, medical school, residency, a peacetime Army tour, then back to Memphis to do a fellowship. During that time, I never treated anyone I knew personally. My portal of entry into a patient's life was through their disease. Especially after my fellowship, where the problems were both visible and palpable, it was easy to start a relationship based on a piece of tissue on a slide and not allow it to progress much further. The need to reconstruct the patient's life story didn't feel urgent. In fact, knowing too much was actually discouraged. It's hard to trace the origins of some of the things we're taught in medicine, but I suspect that the generation of doctors who were my old hometown heroes realized their self-sacrificial lifestyle wasn't sustainable. But that's just my theory. For whatever reason, it was their generation of academics that started telling mine to maintain a little distance, to always remember that the patient is the one with the disease. During the year after my fellowship, I worked for a hematologist who had followed the same career path as those two GPs. He enjoyed the same level of respect and carried the same burden of commitment to his patients. I envied his status as someone born in that community, leaving them and returning, not as a stranger, but as someone born again, coming back to save his people. A shroud of homesickness settled over me, and I finished my year there and made my way back to East Tennessee. The place where I grew up was too small for specialists, so I settled 20 miles away in Oak Ridge. While it wasn't home, I was close enough that it seemed like a connection through geography, genetics, mutual acquaintances, or shared experiences with almost everyone. My patient encounters often opened with, "Do you remember when?" or more often, "You ain't changed a bit," rather than with words like, "What brings you here today?" These weren't strangers with a medical problem. They were people I knew, people who knew or knew about me, people with whom I shared a story that preceded their illness. One of my first patients was a well-respected owner of a small business in my hometown. He came to me with metastatic lung cancer. When his malignancy overwhelmed me, I transitioned my efforts away from his cancer and exclusively toward his comfort. 2 days later, I took a message from his wife that she couldn't wake him up. I hadn't expected him to decline this quickly, so that afternoon I made the first home visit of my career. He and his wife lived over the hill, down in the country a mile or two from where my parents still lived. The blend of my memory and imagination at the time was that they lived in a large house with a manicured lawn on a hilltop at the end of a long, winding driveway. I was surprised to find that his house was on a modest, well-kept lot, but not on a hill. The driveway was long enough but not winding, and the only room in the house big enough to accommodate a hospital bed was the living room. His wife kept his medicines in a shoebox on the kitchen table. There I found 3 bottles of oxycodone prescribed over the last several months, variously labeled with generic and trade names, all of them being administered according to the literal interpretation of the directions on the bottle. He lived comfortably for several weeks after we cleaned up his formulary. He would have died in another day or so had I not made that home visit, and I wouldn't have gone there had I not known him. In the early 1990s, my uncle was diagnosed with metastatic cancer from an unknown primary. He met with an oncologist in Knoxville once, then called me to say he wasn't going back. I didn't and still don't know what brought him to that point, but he convinced me that he'd go home, curl up, and die miserably if I didn't assume his care. Treating old acquaintances added an element of special responsibility to my practice, but this raised all of those burdens and concerns to another level. I didn't have to introduce myself to become a part of his story. I was born into it. I grew up with it. When he called, I could see him lying in the back bedroom of that family farmhouse where he lived alone. I knew the cedar chest with all those pictures was still tucked in the farthest corner of the closet of that same room. I came to resent my family, siblings, cousins, aunts, uncles, one and all, separately and together, for their having the luxury of being able to grieve without feeling responsible for the limitations of modern medicine in general, and mine in particular. For a while, I became a stranger in my own life. It's been 3 weeks now, and my old guy's broken 2 more appointments, one with me and the other with the radiology department, who have declined to schedule him again for a 3rd time. I finish my morning clinic and complete my dictations with a few minutes left to take a walk. I wander through the hospital, past the gift shop, the wannabe Starbucks, the waiting area full of huddled masses, past the glass windows overlooking a man outside in a wheelchair with an IV bag hanging and smoke clouds swirling around a face that holds an expression of smug satisfaction that I imagine is the way Eve looked after she had eaten the forbidden fruit. I move on and out and around the flagpole, circle, down the sidewalk to the parking garage, down again to the bottom floor, walk the full length, and take the elevator back up to the 1st floor. I leave my elevator as an elderly black man exits from the one adjacent. He holds a business card and a piece of paper in his hand. Though my memory of him that first clinic day is quite clear and detailed, I don't recognize him until he says, "Is this you?" And he hands me the card with my name and a follow-up appointment. Time and date, now 2 weeks overdue. I reckon filters into the backwaters of my consciousness. We walk to the clinic. He wears the same outfit as he wore on the first visit, the same shirt, wool pants, and shoes. His hat rides square on his head and doesn't appear to have moved since the first time I saw him. He's talkative today, tells me how anxious he gets coming to doctors, how he can't think clearly and sometimes fears he'll pass out on the floor. We walk across the glass-enclosed bridge that connects the building where we are to the one where we're going. University Cancer Institute is emblazoned high on the outside wall. That's where we're going, I say. He nods. Does it scare you, I ask? Does what scare me? Coming to a cancer clinic. He's quiet for a few steps and says, "You a cancer doctor?" This time I say nothing. "I reckon it does," he says. I leave him at the reception desk, see a patient or two, and then we're alone again in the exam room. "I'm sorry," I tell him. "I didn't realize you couldn't read." Educators say that if you tell children something too soon, you rob them of the opportunity to discover it. For a decade after coming home, I observed and occasionally remarked and often wrote about the stories I shared with many of my patients. Serendipitous associations, such as an old scientist from the Manhattan Project days, an old former veteran who mentioned he spent World War II in the Pacific Theater, both in my waiting room on the same morning, precipitated the memory of stories my mother told me about her brother who was killed in the Battle of Leyte Gulf. These feelings, now becoming too familiar, of being only a speck in the middle of a vast universe, became something that I chose to write, but hide on the page rather than share. I stumbled on Dr. Rita Sharon's body of work describing her observations in the early 1980s, that the skills she needed to take a patient's history are the same as those she used to read and interpret literature. I latched onto this. I even attended one of her narrative medicine workshops at Columbia University. It made sense to me, and it still does. I used what I learned, techniques now widely practiced in educational settings that allow students to experience cultures, religions, ethical dilemmas through reading and reflection before they're faced with it in real life. Over time, I realized that reading a patient as a piece of literature didn't seem to match my personal experience. Many of my patients were people with whom I already shared a story, so reading them to engage, absorb, and react to their problems was really redundant. I was already there. The patients I didn't know did not come to me as a finished manuscript asking for my critique. They struggled to make me understand their story, comparing their current mysteries to their once upon a time, often using impossible scenarios such as the man with pancreatic cancer who compared his abdominal pain to a cold ball of fire in his belly, or the younger woman with Hodgkin's lymphoma who described her itching as tiny little explosions under the skin. I stopped trying to read the patient. I accepted my place as a character in the stories they were telling, and I continued my search for meaning by writing our stories. The structure of a story is often illustrated as a graph, beginning, rising upward, then resolving downward toward the end, as if each segment builds on the other, then moves on without looking back. It's better illustrated by a Venn diagram, I think, composed of 3 partially overlapping circles. The beginning originates in the lower left circle, then moves upward to the top, comprising the middle segment of the story, filled with conflict and controversy that escalates unbearably until a climactic event allows the story to decompress into the lower right circle, where lives the ending. The area where the beginning, middle, and end overlap is the writer's workspace. This is where the artist's unique creativity allows the beginning to affect the middle, and both to define an ending that seems inevitable, one that may be abrupt and brutal, or one that resonates with ambiguity, but always leave the characters forever changed. It is this small area where the infinite number of stories are created from a finite number of themes and patterns. Evidence-based medicine is also characterized as a Venn diagram. Resting at the base of this triangle on the left is the patient's preference and actions, the clinical description of their once upon a time. The top circle overlapping the 2 at the base contains the clinical circumstances, which is analogous to the middle story, or the disruptive changes that have disordered the patient's storybook beginning. Unlike the Venn diagram in the story, the circle at the right base is not the ending. It contains the available research evidence that is relevant to the patient's story. In medicine, the point where the end of the middle stops and the beginning of the end starts is blurred. Tumor markers can wax and wane for years. dyspnea from heart failure, encephalopathy from advanced cirrhosis, dialysis-dependent renal failure are all amenable to meaningful management for prolonged periods of times. Just like the story Venn, the most important area of the evidence-based medicine Venn diagram is the little space where all three circles overlap. This space contains a little fragment of the science, a piece of the patient, along with the generous helping of their clinical situation. This is the part that holds it all together. It's analogous to the writer's role. It's where we exercise our clinical judgment, use our expertise. Acquiring clinical judgment, like becoming an effective writer, is a cumulative process. With practice and time, we can accrue a broad blend of knowledge and experience that is tempered with our own unique recipe of geography, culture, and beliefs. Clinical judgment is neither science nor art, and it is both. It is the thing that separates clinicians from scientists and artists, and is the precipitate when the two are mixed. Clinicians using sound clinical judgment don't write toward an ending that delivers revenge or victory or defeat. We manage the end. We use science and art to reconcile differences in health and healing, death and dying, the journey and the destination. We make the patient feel comfortable, comforted, and at the end, complete. It's an end of the summer day in the clinic, and I'm working a little later than usual to atone for a week at the beach. I'm reviewing a stack of lab work that's accumulated while I've been gone, page after page of bone marrow reports, cytogenetic and molecular studies on people who are waiting on a phone call or a follow-up clinic visit. Most of the molecular studies I review are normal, which causes me to muse over the price we pay for the disquiet of an accurate diagnosis, especially when the denominator includes all of the normal results that I've generated. Which then transports me back to that early summer day when I happened to meet the elusive black man with the straw hat, tropical shirt, and wool dress pants, and now the certainty of a malignancy in his bone marrow that still is not completely evaluated. The memory of my great-grandfather's image is attached to that clinic visit. Unlike my patient, the last sentence of his story was chiseled along the bottom edge of his tombstone less than a decade after that photo was taken. Shot and killed in a pistol duel, October 1893. His grandson, the uncle I reluctantly treated, floats to the surface of my consciousness, causing me to wonder where I'd be had I not learned the lessons he taught me in the 6 months of his dying and the 25 years after his death. I might have eventually learned that my patients really don't want me to be objective, but I would never realize that objectivity is important to patients too. Had I not been his nephew, I'm certain he wouldn't have accepted the chemotherapy that I offered. And then I'm time traveling back to the 4th floor of the Methodist Medical Center in Oak Ridge, where I stand at the bedside of the older of those two GPs to extend my condolences to his wife. The contrast of this man who towers over everyone in my memory, now rendered small and frail from the ravages of age and illness, overwhelms me. I recall the smell of new-mown grass, flower-bed mulch, the feel of cool window glass on my hands. My throat tightens, leaves me unable to say the consoling words I'd rehearsed in my mind while walking over from my clinic. His wife takes my hand, graciously gifts me with the beginning, middle, and ending to this talk 20 years before I knew I'd need it. He was so happy, she said, that his doctor wasn't a stranger. Thank you.
Are there questions, comments, fragments of stories that you have encountered recently? While you pause and think about that, let me introduce Dr. Caine's wife, Priscilla Caine, his youngest son, Adam Caine, football coach, Sequatchie County, pulled for them in the playoffs. Your thoughts? My patients, like your patients, end up being as valuable in some ways as our professors. How do we maintain confidentiality when we want to take their stories into print, or feature them as you did in this wonderful essay in the Annals of Internal Medicine, Letters from the Grave. How do you protect the confidentiality of this story and still convey it?
It's a lot harder now than it used to be. You can ask permission from the patient and ask them to read the transcript nowadays if they're still alive. That particular essay, no one in it was still alive, but it was in the town where everybody knew them. I changed enough of the details that I don't think it was recognizable, and to date no one has come up and asked me who that was. But I think just a few years ago, if you changed enough details, it could be accepted and published in that state. I think now it's recommended. In fact, if we're doing case reports in Knoxville, the residents go through the IRB and get permission to review the chart and publish even small little vignettes if it's very recognizable. That particular essay I'd forgotten about, but that man mailed me a plaque that I still have hanging in my study. It was a Pretty Good Guy Award. That was the name of it. He commissioned it before he died. He knew he was going to do all this. And it was a long time before I could put all that on the paper just because that plaque was looking at me the whole time. So and stuff like that happens a lot.
You've improved our day, and thank you for giving the Winston P. Caine Memorial Lecture.
Thank you for having me.